three should be at least present for diagnosing the disease as atopic dermatitis. In minor or less specific features, there are xerosis, periauricular fissures, ichthyosis, hyperlinear palms, keratosis pilaris. Keratosis pilaris, in this follicular papules are present mainly over the extensor aspect of arms and thighs. IgE reactivity means when we will investigate the patient, then serum Ig level will be raised more than 1000. Okay. IgE, RAS, or what is RAS? Radioallergy sorbent test. Okay. At least you should be knowing full form. Or prick test positivity, hand or foot dermatitis, scalp dermatitis, susceptibility to susceptibility to cutaneous infections as like Staphylococcus aureus and herpes simplex, because the patient is continuously itching, so the barrier gets disrupted and gets prone to the infections, mainly by bacteria or virus. Okay. When herpes simplex lesions occur over the atopic person, there is another term, means another condition known as eczema herpeticum. Okay. For that, mainly you should be knowing only the term and no need to go in detail. Then perifollicular accentuation, especially in the dark and pigmented races, like Indians. Now, distribution and character of rash. There are three phases. Phase of infancy, which mainly occur between birth to 2 years. Okay. And it is acute and involve face and trunk, sparing the napkin area. In infants, napkin area is also spared, and in face, perioral area is also spared. Only the cheeks are involved, basically. Okay. In childhood, back of knees, front of elbows, wrists and ankles, and in adults, face, trunk and lichenification is commonly seen. Here we can, in this picture, we can see that back of knee is involved and the lesion is erythematous, ill-defined plaque. And here we can see the cheek areas are involved. In this, the lesion has extended to perioral, but in subsequent picture I will show you that characteristic cheeks are mainly involved. Okay, and lesion is erythematous and the boundary is not well defined, so ill-defined plaque on cheeks. And overlying scales are present. Here we can see. See, in this picture, mainly the cheeks are involved and perioral area is relatively spared. Okay. Here the antecubital fossa and popliteal fossas are involved. That is the flexural areas. Now, what is the difference between acute and chronic atopic dermatitis? The acute lesions are red, swollen and have ill-defined margins. And the initial, that is primary lesion, are basically papule, vesicles or large blisters. Right? There will be history of exudation of any kind of fluid and cracking of the skin. But in chronic lesions, the lesions are less vesicular and less exudative and more lichenified, which is secondary to rubbing and scratching. And there may be fissuring and the history of scratching will be present. Now, epidemiology, age of onset, 60% develop in 2 months to 1 year of life, and 30% in between by the age of 5, and 10% develop atopic dermatitis between 6 and 20 years of age. The adult onset is rare in this case, in this disease, and more commonly seen in males than females. This is it basically depends on research basis, because in Indian scenario, females are mostly restricted to household works, and males are more exposed to the outer environment, so they are more exposed to allergen on this basis. They are saying more common in males, but it can vary. The cause of atopic dermatitis is multifactorial and not completely understood, and causes include genetics, skin barrier dysfunction, impaired immune response, eliciting and exacerbating factors. In eliciting and exacerbating factors, there can be food like seafood can cause allergy, nuts, and dairy products, eggs, and some pollen grains can lead to allergy. And skin barrier is mainly maintained by the filaggrin gene. And when there is mutation in the filaggrin, then the person is having this disease since birth. And inheritance pattern has not been asserted. And atopic dermatitis mainly seen, the prevalence is higher in children whose both parents are affected. I have already told about the filaggrin gene. What is filaggrin gene? Filaggrin protein. It helps in aggregation of keratin filaments during the terminal differentiation of epidermis, and it is important component of barrier of skin. At least you should know that filaggrin is a protein involved to maintain the barrier of skin, and when the barrier is disrupted, it means there is some problem in the filaggrin gene. Here we can see that skin barrier is normal. There are some, and what is NMF? These are the natural moisturizing factors present in the skin. And when the skin barrier is disrupted, we can see there is cracking between the cells, and natural moisturizing factors are also reduced. And there is increased transepidermal loss of water. Okay. Now, eliciting factors can be some kind of aeroallergen like dust mites and pollens, microbial agents like exotoxin of Staphylococcus aureus may act as a superantigen and stimulate the T cells and macrophages. Autoallergens like IgE antibodies directed at human proteins cause release of autoallergen from the damaged tissue, which trigger IgE or T cell response. Mainly initially what happens in the pathogenesis of atopic dermatitis, there is Th2 response is higher, and in chronic case Th1 immune response is involved, and the cytokines which are basically involved in the pathogenesis of atopic dermatitis are interleukin 4 and interleukin 13, which cause the disruption of epidermal skin barrier. Okay, and so the treatment will be targeting these interleukin 4 and 13, which I will be discussing in subsequent slides. In food, I have already told eggs, milk, soya bean, fish, and meat. Some people can be allergic to these food items. Now, exacerbating factors, skin barrier disruption. There is increased transepidermal water loss by frequent bathing, hand washing, and dehydration. So, the patient is advised not to use hot water. He should use lukewarm water and can add some drops of coconut oil in the water which he is using for bathing, and less use of soaps because they also contributes in damaging the epidermal barrier. So once in a week or twice in a week he can use, the patient can use soap, and basically glycerin containing soap like Dove or Pears, like that. Season, atopic dermatitis improves in summer and flares in winter. Infection I have already discussed earlier, Staphylococcus or herpes. Fungus is rarely associated with the atopic dermatitis patient. In clothing, wool is an important trigger. So the person is advised to wear some cotton cloth first, and over that woolen clothes should be worn. Okay. Emotional stress is also an exacerbating factor for atopic dermatitis. Now diagnosis. Atopic dermatitis is typically diagnosed by the UK diagnostic criteria or Hansen or Rajka criteria. Skin biopsy is taken, prick test is done, patch test is done, bacterial and viral swab, total and specific IgE antibodies are checked and discharged. Basically, if it is positive, then it suggests dust mite allergy. Okay, skin biopsy mainly shows some certain types of white blood cells. Eosinophils are elevated, serum IgE elevated, and um, in skin biopsy, spongiosis is seen in the histopathological finding because it is an eczematous condition. So spongiosis is main feature. Okay. Now management. Primary prevention is regularly we have to advise that a regular moisturization is very essential. Moisturize the skin at least twice a day with creams, ointments or lotions. Identify and avoid the trigger that worsen the condition like sweat, stress, obesity, soaps, dust and pollen. And advise the patient to take shorter baths or shower. And use warm water rather than hot water. Some are advised to take a beach bath in order to decrease the bacterial or viral infection of the skin. And only gentle soaps are advised. And dry